Welcome, welcome. You are tuning into Koruna Talks on the front lines of your health, hosted by Anoko House and Columbia University's Black Alumni Council. This is the first of several conversations that we're having on COVID-19 and how it's impacting communities of color from health, business, and financial perspectives. I want to thank you for your time. Thank you for prioritizing this important conversation about health. I always find it comforting to look to words of wisdom and guidance from artists. And from Maya Angelou, we learn strength. As she says, when my bones are stiff and aching, and my feet won't climb the stair, I will only ask one favor. Don't bring me no rocking chair. When you see me walking, stumbling, don't study and get it wrong, 'cause tired don't mean lazy, and every goodbye ain't gone. I'm the same person I was back then, a little less hair, a little less chin, a lot less lungs, and much less wind. But ain't I lucky I can still breathe in. All of us here are alive, and that's something to be thankful for. My name is Shemite Obialo, and I'm founder and CEO of Anoko House, which is an international membership club for culturally savvy global citizens who are passionate about building wealth, and particularly building wealth across communities of color and the global African diaspora. Now, there is such a need for a conversation like this that I'm happy we were able to pull it together. And I want to really shout out some of the many people and organizations that made this event possible in just a few short weeks. I want to thank our co-host, Columbia University's Black Alumni Council, and shout out Riley Jones, who has been so generous in going with me on this journey and really showing a lot of stewardship and leadership of the Columbia alumni community. I want to thank our co-sponsors, the Association of Black Cardiologists, an organization founded by Dr. Richard Allen Williams in 1974 to address the adverse impact of cardiovascular disease on African Americans. And within the ABC organization, I want to give a special shout out to Alan Merritt, our resident IT expert, Cassandra McCullough, the Chief Executive Officer, as well as Rachel Williams, who is our social media guru. And the ABC has been doing some really incredible webinars that are really educational, and we're going to be dropping some of those links in the chat, but also sharing some FAQs that the ABC has been putting together. Just really amazing content hosted by medical experts on COVID-19 and how it's impacting us. Also like to thank our co-sponsor, the National Minority Quality Forum, an organization founded in 1998 by Dr. Gary Puckrin to leverage evidence-based data-driven initiatives to guide programs to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities. And you'll hear from Dr. Puckrin later on in the discussion. And really excited about a special announcement that we actually now have a media partnership with Black Enterprise, and we're going to be streaming on all of Black Enterprise's social media channels. That's including Facebook, LinkedIn, Instagram, and Twitter. So we'll share around the link to that where you're going to be able to access that live stream after this talk. So just to give you kind of an overview of the format, we're going to be doing about an hour of conversation. We may run about 15 to 30 minutes over just with Q&A, but we're really going to try to stick to time. And we also have a chat going. If you have anything you want to share and just kind of create a nice dialogue within the group, feel free to add it in the chat. And I'll be adding in links in the chat as well, just informative links as we go along in the discussion. But really the bulk of this conversation is going to be a Q&A, and a lot of you guys who registered submitted questions, and we have really been careful to curate that list of questions, and we're going to be pulling from that as part of this discussion. And we also are live streaming on the ABC's Facebook, so we're going to be pulling in some questions from Facebook as well. So this is really going to be an interactive discussion. But without further ado, I'd like to introduce my co-moderator for today, Dr. Elizabeth O'Feely. And really she is the absolute reason why this panel came together with her outreach to her powerful network. Dr. O'Feely is professor of medicine at Morehouse School of Medicine and a practicing cardiologist. She's a national and internationally renowned clinical scientist with a particular focus on cardiovascular disparities and women's health. Dr. O'Feely has helped raise over $150 million to fund pioneering research and training at Morehouse School of Medicine. And she's also an elected member of the National Academy of Medicine, which is considered one of the highest honors in the field of health and medicine. She's a founding member of Anoco House, and I'm proud to call her mom. So without further ado, please welcome Dr. Elizabeth O'Feely.
Thank you so much, Shimita, and thank you for those really kind words and introduction. I want to welcome all of you as well. This is an amazing opportunity, and we are so glad as the Association of Black Cardiologists to be a part of this. And you will see that our renowned panel members are folks that you've seen on TV, on CNN, and they made time, all volunteer effort, to come to help us, to educate us about this important topic. I will introduce our speakers now, and then we will go into some Q&A. Dr. Patrice Harris is a renowned child and adolescent psychiatrist and serves as the 174th president of the American Medical Association, the first African-American woman to hold this position. Welcome, Dr. Harris.
Thank you very much. What a wonderful opportunity.
And then we have my friend and colleague from across the pond, Dr. Carlos Del Rio. Dr. Del Rio is a distinguished professor of medicine at Emory University School of Medicine and professor of global health and epidemiology at the Rollins School of Public Health of Emory University. Welcome, Dr. Del Rio.
Thank you. This is great.
Then we have my friend and partner as we navigate efforts with the Association of Black Cardiologists, an amazing physician, and as you'll hear, has done an amazing amount of work with the COVID epidemic on behalf of the Association of Black Cardiologists. I am pleased to welcome Dr. Michelle Albert, who is the president of the Association of Black Cardiologists and a professor of medicine at the University of California, San Francisco. She's also the Dean of Admissions for the UCSF Medical School, and this appointment is effective on July 2020. She is also the director of the Center for the Study of Adversity in Cardiovascular Disease called Nurture Center. Welcome, Dr. Albert.
Hi, everyone. I am thrilled to be here.
And I am also pleased to welcome Dr. James Maine. Dr. Maine is Vice President, Science and Regulatory Advocacy at Pharma, a trade group representing companies in the pharmaceutical industry in the United States, where he provides leadership for pharma involvement in a number of science-based public-private partnerships and works to support pharma industry efforts to evolve the contemporary research and development ecosystem and the drug development pathways. Welcome, Dr. Maine.
Thank you, Dr. O'Feely, and thank the organizers for this opportunity to join this very distinguished panel.
Thank you. And as you heard, also a co-sponsor of this, Dr. Gary Puckrin. Dr. Puckrin is the President and Chief Executive Officer of the National Minority Quality Forum a not-for-profit organization that he founded in 1998. The National Minority Quality Forum uses evidence-based data-driven initiatives to guide programs to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. Welcome, Dr. Pochran.
Thank you, Dr. Healy. Glad to be here.
Back to our co-moderator, Shimite.
Thank you so much, Dr. Ofili. So the first question that, that we're gonna ask really has to do with how does the COVID-19 virus attack our bodies? Like to discuss in particular what I'm reading and seeing about the ACE2 protein, which is a powerful protein responsible for many productive functions in the body, and it's pervasive in the body. We know that the coronavirus binds to the ACE2 receptor, and so because of that, that's why we're seeing some of the manifestations of varying degrees. Loss of smell, we may see some things happening in your gastrointestinal tract. Of course, we see challenges with the lungs. So if you could, maybe Dr. Albert, Dr. Del Rio, talk to us about how does the coronavirus attack our bodies?
Well, let's first, thank you very much. Let's first mention the fact that coronavirus is a family of viruses that are typically the cause of 10 to 30% of respiratory infections. But there's a group of coronaviruses called the beta coronaviruses that do more than just cause a cold. And they include the SARS coronavirus, the MERS coronavirus, and now this novel coronavirus called COVID-19. So the first thing is, while the virus is a respiratory virus and they get acquired as a respiratory virus, they're more than a respiratory virus. They really invade the body and they cause disease systemically. And they do so by attaching, as you mentioned, to this. The viruses do not live by themselves. They're just a collection of proteins and nuclear material, but they need a cell to survive. They need a cell to replicate. And they do this virus uses as a key the ACE2 receptor to enter cells. And ACE2 receptors are present in lungs and heart and GI tract and the kidney in many places. And in fact, they're critical in cardiology. And you'll hear about that later, how this blocking the ACE2 receptor, manipulating the ACE2 receptor is critical in controlling high blood pressure and treating people with heart failure. So the virus is using something in our body that is very important in regulation of blood pressure, and that's how it gets into the body. Now we know that ACE2 receptors increase with age. So for example, young children don't have as many, older people have more. And we are learning more about how those ACE2 receptors have to do with the pathogenesis of the virus, because then this will be probably an important point of blocking and of attacking, of making sure this virus prevents it from entering the body. So we're learning a lot about the pathogenesis of this virus. We're also learning that a lot of the disease that we see is not just the virus, but it's actually the immune system responding to the virus, creating this enormous inflammatory response to the virus. In some people, not in everybody, that tends to make patients very sick and end up in the ICU. So a lot of things that we still don't know, but I think a lot of learning that is happening. And I think this virus has created a bond between infectious disease physicians and cardiologists in trying to understand and tackle these issues.
Got it. And that immune response you're talking about, I've heard it's a cytokine storm, something along those lines.
Well, our bodies respond to infection by using proteins called cytokines, and these are very important in causing fever, and inflammation is good. It prevents us from, it helps us attack an infection, but inflammation can go crazy sometimes, and you get diseases like lupus, or you get diseases like rheumatoid arthritis, you get autoimmune diseases, but you can also have those inflammatory proteins be released like a storm, and then you create those proteins start damaging your body, and that's what we call a cytokine storm. It's almost like the fire department is now attacking you, basically.
I was going to add that I think we can think of coronavirus in several different phases. I think classically people are thinking about it in 3 phases, wherein the virus infects the body, as you've heard, through the ACE2 receptor. And that's like a viral replication phase, which occurs during the first 0 to 14 days of infection. And then thereafter, you get the uptick of this host immune response. So all of us have a response to infection, whether it's viral or bacterial infection, in this case, viral infection, that then picks up. And in some of us, that response might be more exaggerated than others. And in the blood, we can measure various substances, including things like interleukin-6, C-reactive protein levels, blood levels that measure clotting factors, which I'm sure we're going to talk about a lot later, that represent a reaction or in concert with this host immune response. I know as a cardiologist, one thing that's come up as it relates to the ACE receptor is whether or not people should, continue taking medications, blood pressure medications, called ACE inhibitors or angiotensin receptor blockers, since they affect the ACE, the entry of the virus into an organ. And the recommendation that all cardiovascular organizations have given is that do not stop taking your blood pressure medications. Please continue to do so while the clinical trials are ongoing and the basic science studies are ongoing to better understand what is actually happening in relation to them.
Got it. Thank you.
Thank you so much, Dr. Albert. So we have reached a very, very grim milestone with the coronavirus. Just yesterday, the news channels have reported we passed 100,000 fatalities, specifically 100,846 as of last night. And we have 1,707,227 cases reported as of last night. I just want to ask all of us watching on this webinar, let's just observe a moment of silence for the devastation that this virus has caused in our community. Thank you. An important question for us on this webinar, as well as in life in general, as we're hearing from the news, is the question, why are so many Black people dying from the coronavirus? We understand from the data that Blacks are facing higher infection, hospitalization, and death. It is important to note that there is no genetic predisposition that makes Blacks more likely to have the disease. However, we recognize that Blacks are 25% of deaths overall, and they represent only 12.9% of the population of the United States. More distressingly, Blacks are dying at almost 2.5 to 7 times, depending on the state data that you're looking at, when compared to whites. We will ask our panelists from their respective organizations and personal practice to help us understand some of the reasons and the opportunity to mitigate these reasons. There's some things we know. The economic circumstances, for example, the types of jobs. Blacks and other people of color tend to have jobs that put them in close proximity. Whether you're looking at bus drivers or transportation, or those who work in the hospital, or those who work in the grocery stores, often they cannot practice social distancing. And we all should acknowledge at this point that social distancing is a privilege. There is also bias within the healthcare system, and this has been well documented. And what results from this, of course, is that there is a mistrust within some in the Black community about whether or not they will receive appropriate care when they do show up. And we have some evidence of this from patients that Dr. Albert has had a direct communication with. I know she'll share with us. There's also the issue of lack of access to insurance or primary care. So if you don't have a doctor to go to regularly, it is hard to take off work to try to figure out how you can get care. There are obviously environmental factors, as Blacks and people of color tend to live in cities where the pollution is worse. And then there's been, unfortunately, a misunderstanding and miscommunication that in the beginning suggested that Blacks could not get infected. Finally, but certainly most importantly, the pre-existing conditions, hypertension, diabetes, kidney disease, these all predispose Blacks, individuals that are poor, and other people of color to this disease. I am now going to ask our individual panelists, beginning with Dr. Gary Puckrin, to not only share, because we know the statistic in terms of the overrepresentation of Blacks with the mortality and hospitalization, but share with us what your organization is doing to address the problem. And I know the National Minority Equality Forum has some important initiatives. Dr. Puckrin.
Thank you so much, Dr. Feely. I think the first thing I would remind everyone, sounds a little strange to say, but policy is part of medicine. The ability to access quality health care, we have long had a system that has provisioned health care in ways that put populations at risk. Even now, when you look at the COVID virus, we don't have a good surveillance system. No one can tell me what the denominator is for African Americans or Hispanic or Asians or whites in terms of rates of infection within those populations. And the list that you gave in terms of what may be triggering the excessive death in African Americans, all of those could be in play. So what the National Minority Equality Forum is doing is we want to build the science around this. We want to understand the numbers. Like I tell everyone, we're not physicians. We're like the statisticians at the baseball game. We don't go down on the field and play baseball, but what we try to do is get the numbers together so that those who are playing the game can understand what the numbers look like. So we are partnering with some to do testing within underserved communities, both minority and rural. We're also moving forward to do a longitudinal study to follow particularly African Americans. We don't know what the course of this disease is. I look at Kawasaki disease, for example, that can have residual effect on children into their adulthood. And so there's a real need to get some science around this. And you have to say that it is amazing how far our federal government has been away from helping us understand and putting together the science around this. So in the absence of government really taking initiative here, we're each having to do what we can do. So we're building this coalition that's really gathered around the numbers, and we look to partner with clinicians and researchers and really get our arms around this. There'll be other viruses, there'll be other pandemics, and we got to get smart about how we manage all this.
Thank you so much, Dr. Puckrin. Appreciate the sharing the work that the National Minority Equality Forum is doing. I know, Dr. Patrice Harris, that you have been at the forefront of the discussion at the policy level. We would appreciate you sharing with us some of your thoughts around this important disease and efforts that you think is important regards to intervention. Dr. Harris?
Absolutely, and thank you again for allowing me to participate in this very important conversation. I did want to first level set because I think it's something that we all on this panel know. But you know, typically we are looking at the impact on communities of color retrospectively, right? I think it is unusual that we are having these conversations while any particular crisis is going on. So I will say that is the result of people on this panel and others who have raised this issue and called on everyone at the federal and state level to make sure we have the data that Dr. Puckrin just mentioned. So I think we need to level set around that and know and appreciate the fact that we are having proactive conversations. And then beyond that, I call the importance of what we need to do, because Dr. Feely, you laid out the issues, but what are we going to do about it? How are we going to have a conversation about this? And so I call these sort of Dr. Patrice Harris's 4 C's, and they are candor, communication, clutching, and commitment. And so I'll lay out, and the AMA has really been working really under the umbrella of all of these 4 C's, certainly been willing to have candid conversations about this in op-eds that we have written. We have, of course, called out the social determinants of health, but moving one step further, we talked about the structural determinants of health. And we have laid out and called out past issues regarding racism, both structural and personal, and discrimination and biases. Those are difficult conversations to have, but we have to be candid and have those conversations, which gets to communication. And we have had, in addition to our op-eds and other articles, viewpoints that I have written, we have had several town halls. The AMA has sponsored several town halls with different communities of color to elevate these important issues. I mentioned clutching. What we are doing on this call is we are not pearl clutching, right? We are not saying, oh my, and that's what we have to guard against. We are talking about what we have done and what we can do, and that will be necessary. And finally, commitment. I'm not worried about anyone on this call, but we have to make sure that there is a commitment from everyone, again, to get beyond the pearl clutching and decide what we're going to do. So from the AMA standpoint, we're going to continue to promote the science. We were early in calling on Congress to make sure we get the data regarding race and ethnicity, but also zip code. And Dr. Puckrin mentioned testing, right? We need to make sure that we know where the testing is occurring, and is it occurring in communities that have been impacted the most. So we have to make sure that we get the data, and the AMA called out the need for that data. And I'll finally say, hopefully many of you know that the AMA has established a Center for Health Equity. It was established about 1.5 years ago, and we have hired Dr. Aletha Maybank as our Chief Health Equity Officer. And our goal is to embed health equity into the DNA of the AMA, and then, of course, in all of our work, both internally and externally. And that does include working with partners in partnership, not only with the government, but private and public partnerships. So that's a little bit of the work we are doing and how the AMA is moving forward on this issue regarding COVID-19, but post-COVID-19.
Absolutely. Thank you so much, Dr. Harris. Excellent. Dr. Michelle Albert, I know you've just jumped out there and implemented a number of initiatives, really action-based, and helped me personally to get closer to individuals that we would not have known about in terms of the impact of COVID-19. Would you please tell us how you and the Association of Black Cardiologists are addressing this pandemic, and specifically the disproportionate impact in Blacks?
Absolutely, Dr. Feely. So I'm pleased to say that the Association of Black Cardiologists has taken a really aggressive posture in our approach to dealing with the COVID pandemic. We have a COVID-19 task force, and we have a multi-level approach to this problem. The first is, and you've already heard we have put out a few webinars that are actually in themselves 5 webinars rolled into one, where we address medical, social, psychosocial, cardiovascular, rare conditions related to COVID, really with an outward face looking at communities of color and disadvantaged communities. We have also put out what we call frequently asked questions that are targeting medical professionals and the general public, as well as the community. So those are also available, and we have distributed them to organizations that we feel would be interested in such documents. We've also published we've done peer-reviewed journal publications related to COVID on behalf of the Association of Black Cardiologists, which we've published in some of the top journals in the United States. So that's the academic and the educational part of what we're doing. And we're going to continue to do that at a grassroots community level as well, where we get in front of barbershops, salons, pastors, the places where folks can contract and spread this awful virus. We have partnered with other organizations, including the American Heart Association, to put out statements, advocacy statements related to PPE early on, very early on, in the beginning of March, first week of March, actually. There were reports were coming out of New York about PPE, and we got on board with several other medical organizations to write a really strong statement to the leaders about the need for PPE. We've also participated in other collaborative statements. We've been involved with the FDA, meetings with the FDA of concerns related to drug therapies and their ability to be able to get to the community at large. We're also interested, like Dr. Puckering, in preparing ourselves and the next generation to be able to address the science and the clinical aspects of this pandemic. So in an additional phase, we plan to support our pipeline investigators in beginning to come up with novel solutions and answers to this crisis, but this crisis as it's embedded in the structural issues as we're all aware of. I think at a personal level, I'm a practicing cardiologist. I am also an academic researcher at the University of California at San Francisco, and I'm pleased to say that I have been the recipient of a really competitive award from the American Heart Association, where they received about 750 awards and awarded 10 to study the impact of COVID-19 in African-American women, to look at the experiences of African-American women. This is a project in collaboration with investigators at Boston University, the Black Women's Health Study. So we're going to be looking at the experiences and perceptions and how they relate to complications and cardiovascular risk in Black women, who are the intersection of the worst economic stress that society can hand down. And also I take care of patients. And so I'm in the hospital wearing PPE as we see and take care of patients. So I would say the ABC is doing a ton. And as usual, we're really care about our community at multiple levels.
Thank you so much, Dr. Albert, and congratulations on that very competitive American Heart Association award that you just landed. That's breaking news, because I hadn't even known about it, and I know I was in a meeting with you just 2 days ago, so that's got to be hot off the press. Well done. Just to add, I noticed that Shemita was sharing the links with you, so we have links from all of our speakers. We have links to their bios, but more importantly, the information that they're sharing with us coming from the American Medical Association or the Association of Black Cardiologists. We want you to go back to those websites and you'll find a ton of information. I do want to add that from the standpoint of the Association of Black Cardiologists, I and others were involved in what's called the CVIS registry, which is essentially cataloging diseases as they present to our members. And this registry has taken on a new life with COVID because people want to catalog what's going on with COVID. That's, again, additional ways that the ABC will, going into the future, continue to explore approaches and therapies. And speaking of that, of course, our expert in this space, Dr. Carlos Del Rio, will share some of his thoughts as far as the disproportionate impact on Blacks and people of color, as well as what he sees as a way forward.
Well, thank you, Elizabeth. And I think a lot has been said, but it just pains me. And again, I hope that, racial disparities in outcomes and in access and in health conditions in this country is nothing new. And COVID is not the exception. We have them in cardiovascular disease, we have it in diabetes, we have it in HIV. And I've been working in HIV for many years. And I'm like, this is the same people I work with. This is the same population. So I think that what I hope is that COVID will be a time that we finally as a country wake up that this racial disparities are unacceptable. And I think I would like to really make a call that we take ending COVID. I think a critical component to addressing COVID will be addressing racial and ethnic disparities in disease outcomes. This is just unacceptable. And when people ask me, why do we have such a high mortality in the US? Why has, we have 5% of the world population, we have 30% of the world COVID deaths. Why is that? And I said, well, it's a legacy of racism. It's a legacy of what we are as a country. It's a legacy of the many, many years that we have seen disparities and a growing income inequality between the haves and the have-nots. And I think COVID is just showing us, and is really showing who the most vulnerable are, is really showing the most vulnerable in our society from an economic standpoint, from a social standpoint, from a disease standpoint, So I think we really need to re-examine who we are as a society, and I would hope that COVID will do that for us. I would hope that we all, really take COVID not just as an infection, but as a symptom, as a disease of our society and of our structural inequalities that we've had for many years. If we had, equal access to healthcare, if we had equal access to preventative care, if we had access to healthy food, to exercise, so many things. I think the mortality in COVID will be very different between minorities and non-minority populations. I think we also have a lot of people who, as you said, they have a lot of skepticism about the healthcare system. So we see people presenting very late with their disease, and that leads to higher mortality. So we need a lot of education. And when I think about going forward, there are two things I think are important. Number one, I'm very involved right now in clinical trials, and for example, in the remdesivir study, ACT-1, ACT-2, I just consented to participants today, and I'm hoping that we continue enrolling minorities into the studies because they need to be enrolled. But as you know, it is hard. There's a lot of skepticism. There's a lot of distrust of research. There's Tuskegee. There's so many issues. And when I think about studies that are going to come happening starting in July, we're talking about some vaccine studies talking about phase 3 studies with 30,000 or more participants each. I just want to be sure that we also enroll the most affected communities, that we use this time to go into the community and really enroll minorities. But again, it's going to be hard because we're going to be injecting them with something, and I think there's going to be risks that we're injecting with the virus. So I think we need to start working, and I'm doing it right now, but I think around the country, we really need to have the community involved, because the answer to this disease is going to be science, community, and policy working together. And again, I think about HIV, and I think an important lesson for me from HIV is how the community has been at the center of the response, and how we as scientists have learned to incorporate the community into our discussions of, reading protocols and helping us and do research, and helping us, get research results back into the community. And, I just completed a study. I was a co-investigator and project and one of the protocol team members for a study called HPTN 083 that looked at a preventive intervention. And I was very pleased that 50% of participants enrolled in the United States were African American. This is the first HIV prevention study, because if you compare that to the Discover study that was done by Gilead, in which only 8% of participants were African American, that's not right. We need to involve the communities most affected, and we really need to make the extra effort to do that. So I think when you say, what is the answer? I think the answer is that we build a trust between researchers and the community. And again, we got to get our policy leaders. I really am, I'm frankly disappointed that I'm not seeing more of our African-American politicians speaking about this disease. We really need them to be in the front. We really need them to be, to talk about this disease, and to talk about how we're going to make a difference. Because, as long as we have as spokespersons people who are, white and male, I think we're going to have a lot of difficulty getting minorities interested. So I'm really pleased that you're doing this webinar, because we really need African-American leaders to really be at the forefront of answering to this epidemic. And same thing with Hispanics.
Yes, thank you so much, Dr. Del Rio. We have lots of questions coming in, and we will have opportunity to respond to them. I just ask people to hang in there. I do want to ask Dr. Del Rio to just opine on this, because it does have implications for the science of this disease and how people can prevent it or be exposed. Someone asked, if someone has had the virus and survived, can you possibly get it from them, especially if they don't have a mask on while you're around them? What is the risk?
So we don't know. We don't know for sure, but we're pretty sure. I mean, knowing coronaviruses, knowing what we know about them, is that if you have been infected and you recover, and I would say survive, recover, whatever you want to call it, you develop immunity. You have some degree of immunity, and you're probably no longer at risk of infected, or even if you're at risk of infected, you probably will get a very mild disease, but you're certainly likely not transmitting anymore. You essentially have recovered. And we know that some people, there's some very nice, elegant studies showing that even though some of those people are still PCR positive, they're not infectious. They don't have live virus anymore. And after about 10 to 11 days after infection, you're essentially no longer excreting infectious virus. So I know people who have recovered, and at least here in the hospital, we ask them to wear a mask, just because, we want everybody to be wearing a mask, and we don't want to say, well, this people are, this people aren't. Again, we can get into this whole debate, this very unfortunate debate on how masking has become this lightning rod for who we are, whether we're liberals or conservatives, when it really is, masking is about public health. Masking is about protecting others. Masking is about being good citizens. So, I think I would worry less about the implications for the person. I would say if it's good to wear a mask regardless of whether you've been infected or not. Very
good. And I see Dr. Albert wants to comment as well. Go ahead, Dr. Albert.
Yeah, no, I wanted to comment, piggyback off of something that Dr. Del Rio was talking about before the masking question, relating to getting communities of color involved in clinical trials. As you know, this is a really, really important issue, something that the ABC has been involved in for decades at this point. I do think that in addition to African American and other leaders of communities of color being involved, it actually does require, though, everyone being involved. And particularly, I think places like the FDA and academic institutions to which some of us belong have to advocate for our colleagues who may not have as much infrastructure as our institutions do to run these trials, to be able to involve those physicians who can, probably recruit those patients more easily. There's more trust. We also there's a need for PIs, principal investigators, who are people of color. This is something that's lacking over and over again. And the typical answer is that they're not qualified people. And that is not true. I just want to put that out there. And then there's the other thing about, sort of encouraging patients and their families to advocate to get to institutions or places where, investigational drugs might be being undergoing clinical trials, so that they can be part of a study and count as part of that 20% or 13% or 15% as necessary.
Right. Shimite.
Thank you so much. So wanted to, you know, it's a good topic. You're speaking about clinical trials and the development of a vaccine. I think that this segues well into the next question, looking at some of the forward-looking therapies and vaccines on the horizon. And so I direct this question to Dr. Del Rio and Dr. Maine. You know, there appear to be several vaccines that are maybe rushed in the works. I know, Dr. Del Rio, you're working on one. You know, could you touch on, you know, what is percolating? What do we have on the horizon? And also, one of our registrants has asked, do you believe that insurance companies will charge us for the vaccine?
Well, you know, important questions. I think that we have been amazed about how quickly we have gone. The time between virus isolation, identification of the genetic material, and the first injection into a human was only 65 days. Never in the history of vaccinology has that occurred so quickly. Having said that, it takes many years, if not decades, to develop a vaccine. And the speed in which this vaccine is being developed, it's lightning compared to that. People are talking about by January having a vaccine. I have my doubts it's going to be that quickly, but even if it takes a year and a half or 2 years, it's still incredibly fast. But then you're going to have to produce millions, if not billions, of doses of the vaccine. And then you have to be distributing those vaccines around the world. And then you need to have equitable access. And I sure hope that, you know, this is not a vaccine that depends on whether you have insurance or not. Let's make sure that this is a vaccine, because the people that need it the most, we've been talking about the poor people, we need people to get vaccinated, period. In fact, you know, we need to figure out a mechanism that we invest in public health and in infrastructure to get this vaccine to the people that need it, and we get it quickly. So I think the issue of how do you get this vaccine to the right people once we have it, I think is going to be a really important ethical discussion, because it may not be who wants the vaccine the most, but who needs the vaccine the most that should get it first. And that, to me, is the most important ethical discussion that's going to have to happen.
Thank you.
If I could follow on Dr. Del Rio's comments. First and foremost, I want to absolutely underscore the critical importance of representation of people of color and all communities in clinical trials. It's incredibly important, not just for the quality of the trials themselves, but also to inform the information that comes out of those trials in the form of administration of the drug once it's available, and its safety, which, as we all know, can vary in different populations. I want to take a page from the AMA and describe comments on progress in both therapeutics and vaccines using 4 Ps: partners, process, progress, and people. When I speak about biopharmaceutical drug development and research, I like to think of it as an ecosystem. And like any ecosystem, it has multiple parts, and each of those parts are interdependent. They rely on each other to deliver their component into the whole. And the coronavirus has really allowed this ecosystem, which has been there all along, to be thrust in the front of the media and the American awareness in a way that I believe shows it in all its glory. It really is a unique and powerful ecosystem that has driven just spectacular progress. So we'll go to another P in a very short period of time. I spent over 30 years of my life developing drugs and bringing them to the patients that need them. I worked on many programs that were the top priority program of their day and needed to move incredibly quickly. I have never seen anything like this, and no one else has either. It's absolutely amazing. So I'm completely amazed by the ability of this ecosystem to move in a coordinated way forward to advance these research and development programs, and to communicate effectively, again, in partnership around these programs. And what I'm not amazed at all by, though, I have to say this, is by the level of commitment and passion that I see from my colleagues and friends in the pharmaceutical research and development world. These are scientists and physicians and public health professionals, just like most of us on this call, and they're passionate about what they're doing, why they're doing it, what their objective is, and there was no question whatsoever. There was no discussion at the beginning about should we do this or why are we doing this. It was all about how do we move as quickly and effectively as possible. And that brings us to progress. There are thousands of clinical trials going on right now. And I'll share that, and this is important for those of you that are involved in the conduct of clinical trials. While there are thousands of clinical trials going on, there are only so many patients. And so we need to place a premium on really directing our resources towards those trials that have the most informative designs and are using the most promising therapies so that we get the most return on that precious investment of patients and subjects in clinical trials. And so process-wise, we've worked at Pharma tremendously frequently with the FDA and with all of the research and development organizations of our member companies. I was just on the phone with these folks this morning, preparing for a conversation with Commissioner Hahn that we're going to have in the not too distant future. Commissioner Hahn is committed to tell us what you need. Tell us how we can help make you more effective, faster, better at what you're doing. And in return, all of the companies have committed to, we will bring you information as rapidly as we have it. We will share information, not just with regulators, which is typical, but with each other. So the programs going on in one company help inform the design and progress and help speed the development of drugs that are being taken by another company. Unprecedented levels of cooperation and partnership. And then this last category of people, I already mentioned the importance several times, the importance of participation of everyone in this process to get the necessary medications to the marketplace. You know, I believe it's going to take not one vaccine, but a number of vaccines before we really can say that we're out in front of this disease and have it under control. And to get multiple vaccines is going to take both a lot of effort and a lot of luck. Everyone has a role to play, not just the scientists and physicians and public health professionals, but everyone is involved in helping to drive this forward successfully. So partners, process, progress, and people, I'm amazed and proud, maybe the fifth P, to be part of this ecosystem.
Thank you, Dr. Maine. Shmita, before, I know you've got other questions to get to, but I just wanted to ask because there's an important question in the chat, and for those of you sending in questions, please know we will get to them because we have allowed a little extra time, so hang in there with us. There was a question about whether the vaccine is necessary if you've already contracted the virus and have developed antibodies. Dr. Del Rio, I think this is an important opportunity to maybe just talk about how, I know you touched on it, but just to emphasize again how much we don't really know enough about this virus. Some of the questions about the antibodies coming up and just how protective they are, we're not as sure anymore. And so put that in the context of the question about should people just plan to get the vaccine, whether or not they believe they've been exposed or however much they think the antibodies levels are.
Well, you know, it's interesting that you asked that because, in fact, as we're designing some of the phase 3 trials, in fact, a prevalence, an antibody is not going to be required as a criteria for entry in some of those studies. We're just going to vaccinate everybody. And then, of course, at some point in time in the analysis, there will be risk stratified depending on the seroprevalence. Just because we know the seroprevalence is mostly very low in our communities, it's at most 8 to 10%, but it's probably lower. So it's not worth doing that. So I want to emphasize that once we know that, then we'll be at, so I cannot answer the question saying what's going to happen once we have the vaccine, because, you know, we may know at the end of the vaccine trials that if you have antibodies, the vaccine is not protective. But on the other hand, we may, you know, one of the concerns that some of us have is that the vaccine could be very similar to the dengue vaccine, in which the presence of disease or antibodies when you get the vaccine actually increases your risk. It actually makes the disease worse. You have something called antibody-dependent enhancement that we saw in the dengue vaccine. So that's one of the reasons why clinical trials need to be done, and we need to include almost everybody to see if, because that's one of the risks that exists in a vaccine, is that you may potentially produce, you know, not protection, but actually the opposite. I I was involved many years ago in an HIV vaccine study, a Merck vaccine, that actually the people that received the vaccine had a higher risk of acquiring HIV than those that didn't get the vaccine. And, you know, again, it really underscores the importance of doing well-conducted clinical trials to be able to address some of those issues.
And I really think it's important. These questions are openers. There's a lot of information will be coming through. What I don't want is for people to just refuse to get the vaccine. We owe it to ourselves and our family members to educate ourselves as these vaccines come into play, so we're being informed and not just going by the sort of general lingo out there that vaccines are harmful, because I think that would be tragic. Shimite.
Thank you. And that last point, that is something that I have heard raised with folks in my community, which is, you know, I don't know if I'm going to take the vaccine because I have to understand the adverse impacts of it. So I think that getting a lot of clarity there would be really, really important. And I look forward to that kind of guidance coming out. You know, we are almost at time, but I want you all to note that we have a long list of questions that we plan to address. And if we don't get to the questions, then we will try to address them in an FAQ that we send around through the ABC. But our speakers have generously agreed to stay on for at least the next 30 minutes, so we can continue to tick through the questions. So I want to kind of start to address some of the questions that we had that came in on the registration page on Eventbrite, but also that are coming in live. I'd like to direct the first Q&A question, official Q&A question to Dr. Harris. I can imagine the social isolation, alienation, and many stressors, including getting sick, job insecurity, is taking a toll on many people's mental health. Could you discuss what you are seeing in your practice in terms of coping tips and, you know, just how to maintain a healthy and balanced mental state?
Well, absolutely, and glad to get the question, because we can never talk enough, in my opinion, as a psychiatrist, about mental health in general, and particularly about the mental health needs that are occurring in the midst of this pandemic. I will say, though, but let's remember, just like we talked about health inequities, that pre-COVID-19, I, as a child psychiatrist, but the mental health community had seen an increase in the number of folks who were reporting stress and anxiety. The number of suicides were unfortunately increasing, particularly in our teenagers. So we have that foundation coming into COVID-19. And of course, we have decades of an underfunded and under-resourced mental health system and lack of access to care. So that's how we started pre-COVID-19. Clearly, this period of uncertainty, the fears and the worries, the isolation, the loss of jobs, the worry about becoming infected, or the worry about family members coming infected, has served to increase all of these feelings: anxiety, worry, depressed mood. We cannot say yet, and we should not, and I have to say we need to differentiate a true clinical diagnosis of depression versus some of these symptoms, all important, but certainly there might be two different strategies to address. Now, the good news, let's first talk about individuals. First of all, people need to give themselves, and that includes me, the grace to feel these feelings. It's okay to be worried. It's okay to be disappointed. There are feelings of grief and loss because of, unfortunately, some folks are losing loved ones, but even folks are losing the ability to see friends and graduate and all those things. So self-care is important. We should try to get as much physical activity as we can, stay hydrated, get as much sleep and rest as we can, eat as healthily as we can, and most importantly, again, ask for help. Now, it's variable from state to state. I know here in Georgia we have a crisis and access line. I know many states and local jurisdictions are setting up numbers for people to call when you talk about the health professionals, my colleagues on the front line who are unfortunately deluged with case after case. and unfortunately seeing no end, particularly in New York. That hasn't been the same across this country. We want to make sure that caregivers, whether you are in the hospital or caring for someone at home, again, practice self-care. And so resources are available. Telemedicine is a very helpful way, and certainly regulations have been loosened around telemedicine, but try to connect with your physician or your therapist through video conferencing. So all of these things are available, and I would say just make sure you ask for help. There is absolutely nothing wrong with asking for help. And in our community, communities of color, there's been such a stigma. So I appreciate the question, glad for the opportunity to talk about it, and please ask for help if you need it.
Thank you so much, Dr. Harris. Next question. If you have tested positive before and you've already been infected and recovered, can you get the virus again? And a related question, which are some of the more sensitive tests? Is it the mouth swab or is it the nasal test? What are your recommendations regarding any of the tests that we need to do in order to kind of measure whether or not we have the virus? And then also perhaps some of the antibody tests that are out there. I think Dr. Del Rio, that might be a good question for you, but any of the other panelists, feel free to jump in.
I think we need to distinguish the tests available. The tests that we have currently for diagnosis are the molecular tests, they're PCR tests. And it's interesting that we started using those tests, and we're using them for two reasons. Number one, because we have done a lot of advancing in molecular biology and molecular laboratories. But number two, again, thinking back to HIV, we have this incredible infrastructure in the country to do RNA testing, to do molecular testing because of HIV. It was HIV testing through RNA, through viral loads that made all these labs exist out there. So that infrastructure that allows us to do RNA testing exists because of HIV, and we're building on it, right? But you know, if this had been another disease, another time, we could have done very different testing. But the molecular testing has become the standard for diagnosis. We're not doing viral cultures. We're now asking pharmaceutical companies to come up with a more simpler test, which is like an antigen test. And some antigen tests have already been approved, which will be a little less sophisticated, a little less complicated than a PCR test, which is a pretty complex test. It's sort of a high complexity test. That's how the laboratory people call it. Now there's the antibody test. The antibody test, it simply tells you, it's not good for diagnosis. It's good to tell you if you've had the infection at some point in the past or not. It's very good. It's being used by public health to do studies in communities to understand how prevalent the disease has been in the community, because we know that many people could have never had symptoms or could have had mild symptoms or were not tested. So we think that for every one person tested and positive, there's 10 others infected in a community. So if your community has 10,000 people we know from New York that, you know, close to 20% of the population has had the infection, and that's done through serological testing. It's not done through the molecular testing. Now, the molecular testing is done using a swab that you have to stick up your nose and actually goes all the way into your sinuses. Having had that done, it's not fun. You feel like they're going to get a piece of your brain when you had that thing done. I mean, if you feel like it's really uncomfortable. So they're trying to come up with simpler tests, even a nasal swab or an oral swab, or even some people we're working in our group and trying to make a spit test, sort of a saliva test that you can do, which would be a lot easier to do than what we're currently doing. So the testing is changing very rapidly. It's advancing very quickly. We didn't have tests for this disease 6 months ago. So a lot of discovery, a lot of things are happening. The antibody test is it's probably the one that is less developed right now. So there's a lot of variability, and CDC recently said don't trust them. And what they meant by that is there are some good ones and some not very good ones. And it's a little bit of the Wild West out there. So until that's all evaluated and certified, it's better not to use it for diagnosis. So if somebody thinks I may have the disease, I could have had the disease, I could have been exposed, doing an antigen test or a viral load test, a PCR test is the way to go. I want to say just one thing, complimenting what Dr. Harris said, is I also want to be sure that we remember of taking care, and I really appreciate her comments about taking care. I think we need to also remember and take care of our healthcare providers. This is a disease that is impacting a lot of healthcare providers. And this is a disease that is really decimating in many countries, healthcare providers, as the attack rate in nurses and physicians and in advanced practice providers and first responders is particularly high, especially in the time where we didn't have a lot of PPE available. And therefore, and healthcare providers are getting burned out. It's hard to put on and put off PPE all the time. It's hard to not have a lot of things to do for patients. You know, it's hard to see people die that you shouldn't see die. It's a very unsettling time for healthcare providers. So I also want to be sure that we continue providing messages of hope, messages of encouragement, and really, thanking healthcare providers. Community has been great about that, about, saying thank you. But I want to be sure that we don't forget that, because, I mean, healthcare providers could have walked out of the job at any time saying, I'm sorry, but I didn't sign up for this. And the fact that they're still going to work and the fact that they're still doing it with a smile and taking care of people really talks about the enormous commitment and the really the passion and the care that people express when they're doing their job.
Absolutely. And, right now, the healthcare professionals are the rock stars in our society. We are depending on them for our very survival. So thank you for that. I wanted to ask,
Shimita, don't forget when you said that all of your panelists are healthcare providers. So just say we're depending on you, us.
Depending on you, and there are many who are even tuned in to this who are healthcare providers. So thank you so much for everybody. Thank you, Dr. Ofili. I'd like to ask, there have been reports of individuals that have survived COVID-19 who are middle-aged and younger, but they're now having strokes due to blood clots, and other kinds of residual things are happening even after you survive. Is there any talk around preventative measures such as low-dose aspirin to prevent this? And just generally speaking, what are some of the health complications after survivors have convalesced? Dr. Del Rio, Dr. Albert, Dr. Harris, Dr. Ofili, please feel free to weigh in.
I'll take that for several reasons. The first is, from a personal perspective, I'll say that, my mom had COVID, was hospitalized with COVID, had 2 MRIs in the space of 24 hours because of the concern of a stroke, had scanning because of concerns of her D-dimer being very elevated, which is a poor prognostic indicator for clots and also for mortality. So your question, Shamia, is real to me. It is also real to Dr. Ofili mentioned and Dr. Sherry, who was on our webinar last week. She lost 2 of her parents in the space of a month from COVID, one likely from sudden death related to venous thromboembolism. So we know that there's clotting that occurs in the context of this condition. I like to think of venous thromboembolism as a cardiovascular condition and largely driven by inflammation. And we know that certainly in the later phase of this infection, that inflammation is sort of running rampant. And what happens is that you get elevations in these inflammatory markers in the blood, you get elevations in coagulation markers in the blood that are distinctive from something that we call in medicine called disseminated intravascular coagulation, which is where folks can develop clots related to severe sepsis or being hospitalized in an ICU. So this is a little bit different. We're still trying to understand what's happening. We think that it may be related to direct infection of the vasculature and also related to inflammation. So because of the concern of the higher risk of strokes, the higher risk of clotting in the legs and the lungs, there has been conversation around, what type of, whether it's an antiplatelet drug or a blood thinner that patients should get. Currently, the general school of thought is that the standard of care should be as it was previously, which is if you're hospitalized and critically ill, that you should get, sort of high dose prophylactic therapy in the hospital for preventing clotting. There's no recommendation about getting aspirin, sort of pre or post. And, depending on where you are, I know, for example, in New York, my mom was discharged on, sort of high dose injectable heparin, which she's still taking because of the concern about clotting.
No, I would say I agree. I think Dr. Albert has put it very well. I think there's a lot of confusion out there about I think there's in a lot of diseases where there's inflammation, you see coagulation, you see clotting activated. This is part of the inflammatory process. But also because, again, going back to what we talked before, because a lot of the people impacted by this disease, older individuals, people with severe disease, people with diabetes, hypertension, are also at high risk of clotting. And therefore, you have a combination of things. I sincerely don't think it's the virus. I think it's the inflammatory process and other things that are happening. But we have learned that is part of what is causing death in patients. So we are very aggressive when people get into the hospital to rapidly use low molecular weight heparin, to do all the necessary things if they don't have risk of bleeding, to put them on anticoagulation to prevent them from having clots and from having this complication. But I think a lot of the information out there has gotten, some people are even saying, oh, this is not a virus, this is just a clotting disorder. No, I mean, I think we need to be very clear about what the pathogenesis in the process is. But clearly, clotting is something that we need to address, especially in people who are in the hospital and sick, because they may get a pulmonary embolus, they may get clotting in their lungs, and they may have complications as a result of that.
And I also think we shouldn't lose the opportunity here to note that clotting and venous thromboembolism has a higher prevalence and incidence in people of color, specifically African Americans. So there is about a 40 to 60 higher prevalence of clot outside of the context of COVID of getting venous thromboembolism. So one wonders, as we sort of take the science out, intermediate and long term, what it might show us in that regard.
So I know we've got really excellent comments from both Drs. Albert and Del Rio. I think the bottom line of the question is people need to recognize that right now taking aspirin will not prevent you from the COVID complication. And in fact, for those people who are really actively sick in hospital or just recently discharged, it takes a lot of powerful anti-clotting drugs because the clotting is just so severe. I would say pay attention to that. I know you're going to have some question down the road about prevention. I think we can talk about that generically at that point. But from the standpoint of clotting right now related to COVID, we're not seeing aspirin as a preventive. It doesn't mean aspirin should not be there. It's part of our armamentarium for cardiovascular disease, because as Del Rio and Dr. Albert said, there are risks related to stroke and some of those in heart attacks, and those can be prevented with aspirin. So those are two different things, and people should not be confused about that.
A broader point about taking medications or reading something on social media or something that someone else said, and then deciding that, oh, that's benign. Aspirin is benign. A baby aspirin is benign. I will just take that. Just everyone remember that there's nothing that is benign, right? And if you take a baby aspirin and you might have what we call in medicine a contraindication, you could bleed out. You could have a severe bleed. So my plea to everyone is just be wary of misinformation and disinformation, and be wary of folks who are peddling vitamins or whatever, and make sure you're getting your information from a credible source, because something that may seem benign could in certain circumstances cause fatal complications.
Wow, that is quite scary to think about. So I want to ask, the country is slowly opening back up. You're seeing folks who are out and about, some wearing masks, some not. It's sort of scary considering the continuing threat of COVID-19. How would you advise people? How would you advise that people assess risk in engaging with the outside world, keeping mental health in mind? Obviously, we need human connection, we need contact, we need to return to work, but how do we do this safely? And a related question, I'll pause there, let that first question, and then move to the related question. So please share, maybe Dr. Harris, Dr. Del Rio.
I would start by saying that, just like the disease disproportionately impacted minority communities, the lockdown and the economic downturn has also disproportionately impacted minority communities. So minorities have gotten sort of the double whammy of having higher mortality and also having higher unemployment and other consequences of the disease. And, it's this a very difficult situation. It's, obviously the lockdown produced just put the brakes in the economy to the point that, we have 30 million people unemployed. We have a recession as bad as the 1920s, the Great Depression. And I think, so a lot of people are seeing this as public health versus economy and which is winning. I think we need to think that, first of all, public health and economy are all related. You cannot have a healthy economy without healthy people. And the question is, how do you advance both, right? How do you make sure that economy and public health advance together? And for that, what we need is to open safely. And I think when I see people going out, I like to remind them that this disease is not gone. This virus has not disappeared. We need to continue doing the right things. We need to continue, wearing your mask and practicing social distancing and washing your hands. And we're going to have to enter a new normal in order to get together before we go into the normal that we used to know. So maybe some things are going to be possible, like I'll be able to get together with some friends at my house or go out in a picnic, but maybe going to 100,000 people, college football stadium to watch my favorite team is not going to be possible this year because of the issues. So I think we need to start stratifying the different things, and we need to start thinking about what is safe. And at the end of the day, people need to look at data, and there's a lot of really nice websites to look at. And I want to really, put in a plug here, and kudos to Atlanta Mayor Keisha Lance Bottoms, who's making her decisions based on data, and who's put together a website called atlantastrong.org, where you can see, first of all, her plan for easing restrictions in the city, but second, also a dashboard of the data she's looking at, and she wants us all to look at in order to make that decision. And I would say a key component is stay informed. Look at your data. Be a smart person, make decisions. I think a lot of people nowadays in their phones, you can get data, you can make decisions. So look at the data, make decisions, and protect yourself, because at the end of the day, it's up to you. If you don't want to get infected, you shouldn't get infected. You should protect yourself. And the more you do to protect yourself, the better we are, because the less patients we have in the hospital. The last thing I say is, I don't want to see anybody more in my emergency room, in my ICUs, in the hospital. Every person I see, I think it's a failure of all of us in public health to do what we need to be doing.
Yeah. We have
Let's remember, I would just add, let's remember why we did the lockdown. Language and words matter. We could have a whole conversation about that, but why we had the restrictions, because we would just think back, we were worried that we might at some point and in some areas have to make decisions about who would get on a ventilator. And we did not want that. And we did that. Everyone in this country did that, so we didn't get there. Now, I do believe we could have done a better job of communicating that that was just the phase and that there would be a next phase, because I think people were worried, are we going to have to stay here forever? So as Dr. Del Rio said, no, but we need to open safely and based on the data. And I'll just say about risk, there's no such thing as zero risk. So everyone should do a couple of things. They should look at their own individual risk. Do they have any health issues? They should look at their community risk. Dr. Del Rio said what we're doing in Atlanta, no detailed data about the spread in your community. And then they should measure two things. Outside is better than inside, right? 12 feet is better than 6 feet, but 6 feet up minimum. If you're going to socialize, bring your own stuff, have a picnic, but everybody bring their own utensils and food and all the related accoutrements. So we can, again, continue to progress, just do it safely. But by all means, absolutely, everyone should wear a mask and practice good hand hygiene and hand washing.
I wanted to make a comment as well about, since we are, concerned about vulnerable communities and communities of color, about this tug of war between the economy and public health. It is all of our responsibility to ensure that communities of color are not sacrificed in the benefit of economic upturns as we go forward. Because, I'm sure you can remember not too long ago when we were talking about surges, there were concerns about ventilators. Who might get a ventilator? Who will not get a ventilator? Who's too high risk to get a ventilator? So I think that all of us need to remain, sort of fairly diligent and understand that, within the context of discrimination and segregation that are longstanding, it might be not so difficult to repeat, sort of the darkest elements of our past with this pandemic. I think that, sort of from a public health perspective, when is it safe to come out? It's safe to come out when, cases are no longer spreading widely, right? When the healthcare system can withstand spikes and mitigate risks to healthcare providers and patients' lives. And then our public health capacity, the ability to test, trace, isolate those who are ill, and to quarantine contacts. So these, I feel like are the ABCs essentially of when is it safe for communities to open.
Thank you, Dr. Albert. And I think that what I do find, as a positive here is there's such a galvanizing of the private sector in terms of how can we innovate areas which may have been outdated, whether that be the rapid development of a vaccine and tests like Dr. Del Rio was mentioning, or just rallying to create PPE and just individual companies coming up with 3D printers and that sort of thing. So that is very inspiring that this kind of wartime effort has happened. A couple of comments in the Q&A that sort of address maybe some of the ways that we can equip ourselves to go back out into society, just building up our immune system with vitamin D, with vitamin C and zinc, and then maybe just the use of social media influencers and just sort of setting the pace and tone for what we need to be doing. Folks like Cardi B and Chris Rock have been pretty vocal in imploring Blacks and Hispanics to follow simple guidance in terms of the mask and the distancing. So I think that just really creating some collaborative partnerships between the healthcare community and the social media influencers and celebrities who have such sway in what people do would be really powerful in the ongoing fight. I think that we have time for probably just one or two more questions. So I'll ask, with the spread of this virus, do you believe that this will be totally eradicated, or is this going to be a way of life going forward? Dr. Maine, Dr. Del Rio, anybody who'd love to comment?
I think we're going to be entering a new normal, a new temporary normal in which we're going to have to practice, as I said, behave different. And I think we're going to have to learn, as Dr. Harris said, we're going to have to learn what is safe and what isn't. And we need to, who we need to take care of and what we do and how we do it and how we, how we behave. And I think it's going to be a difficult time, but I think it's not going to be forever. This too shall pass. I think science is going to catch up with us. I think we're going to be in a better place. What I hope is, again, I insist on this, that I hope that at the end of this, when people say, when are we going to be able to be back in the normal we knew. I hope we move forward to a new normal, to a more equitable normal, to a more equitable society, to a more caring society, to a society that invests a lot more in public health. I mean, the reality we had as a country disinvested in public health. The reason our public health laboratories were not ready to do the work they needed to do is because they were not capable of doing it. They didn't have the equipment, they didn't have the personnel. So I think we need to go back and invest appropriately in public health. I think we need to also do I would say, a very good look at where we were and why didn't we respond before? What were our pandemic plans? What failed in those plans? Because we had great pandemic plans, we thought, and obviously they didn't work. So what do we need to do to make them work? So I think that, again, we're a resilient society. We're smart, we have a lot of good people, and I think we all need to, we'll get over this by working together, but it's gonna be, this is gonna be not easy, and we just need to be sure that we do it with the least, disease and death among our fellow citizens.
Shimita, I know you're coming to closing comments. There was a question about herd immunity. I think it'll be important to just touch base on it. And then dovetailing with that, there was a question about, vaccines and guinea pigs and African Americans. Maybe we can just talk a little bit and maybe just a couple of panelist members speak to this. Dr. Del Rio, if you can just speak very briefly about the notion of herd immunity and, for example, the disparate responses for a small place like Sweden that didn't lock down at all from what we're doing here. And then maybe just have both Drs. Harris and Dr. Albert speak to how do we overcome some of the distrust as we go forward with these clinical trials and vaccines. And again, I know these are long and tough questions that we will continue to tackle, but I just wanted maybe we touch upon them before we close out the webinar. Dr. Del Rio.
So herd immunity is a concept that I like to describe as community protection, right? And it's how much disease do you need in the community? How many people who already have the disease who are immune, and how many people who are vaccinated you need? And by adding those two, what kind of protection? So you have less susceptible individuals, and therefore more people are protected. And the herd immunity percent is very related to the R0, or the rate of the transmission of the disease. And a disease like COVID is probably somewhere in the 60% range. So you will need about 60% of the population. We would never be able to get there just by disease. I mean, as I said, even in New York, 20% of the population have been infected. That's still very far from 60%. But in most places like, where 5% of the population have been infected, it would be a lot of people need to, we think in the US, maybe 10 million people have been infected. You would need to infect about 280 million Americans to get to herd immunity. That would mean even if at a mortality of 1%, that would be just a ridiculous amount of people dying. I mean, that 2 million deaths in order to get there. So we simply cannot, the human toll of herd immunity is simply not acceptable. So that's when a vaccine plays a role, right? Because if we had a vaccine with 40% efficacy, plus a 20% herd immunity, you would get to that 60% so you don't need a perfect vaccine. You need a vaccine with 40%, 50% efficacy to get there. Let me just say that while Sweden tried this and didn't work, I'm worried that the US, as it's opening, is becoming a Sweden. And I just want to be sure that, again, what Dr. Harris said, that we continue to protect ourselves, because as we open schools, as we open businesses, we need to be sure that we keep transmission low, so we keep disease low, and we keep mortality low, because otherwise we're going to have a lot of pain, social pain, a lot of pain in our healthcare system, and we're going to have to be making some decisions that we'd rather not make. So again, herd immunity is not the way out of this epidemic.
Thank you. We've got a couple of minutes. Dr. Albert, you get a minute. Dr. Harris, you get a minute. And then we wrap up.
Sure. I think you wanted us to address this issue of mistrust and in terms of patients. I think what we can do as organizations is actually, sort of prepare, public service announcemements that get to the issue of mistrust as we try to get patients back into healthcare systems and get those who weren't in the healthcare system in the first place to think about coming into the healthcare system. I think that, again, as I mentioned earlier, as it relates to these clinical trials, that it's going to be very important to have minority investigators be very involved in these clinical trials, and in fact also be the main PIs of these clinical trials in order to develop studies that sort of really take into context a lived experience and not be predatory to communities of color. Communities of color are accustomed to being having predators come in and thus locked down in that regard. And we know from cardiovascular data, for example, that patients who are of similar race and ethnicity, especially African American, to their cardiologists, they're more likely to adhere to recommended therapies. I think the same school of thought moves along with clinical trials. And I think also developing advocates for patients and their families so that to help them advocate navigating the healthcare system and getting to places that they may need to get medical care. In my instance, and I know you said Dr. Philly 1 minute, but I do think this is important. I made a very tough decision when my mother was decompensating to not send her to a hospital in the neighborhood where she lived. And in fact, not call 911 because I was concerned about the care that she could potentially get. So instead, we made a decision to put her in a car and take her to a hospital where we thought that she would get better care. I'm a cardiologist and I'm having to make those sorts of decisions. And I worry about others who can't make those sorts of decisions or who are in the same spot as I, having to deal with family members.
Thank you, Dr. Albert. Dr. Harris.
So quickly, yes, we all have to commit to a world where we don't have to make those types of decisions, and that is none of us have to make those types of decisions. Quickly about Sweden, as Dr. Del Rio said, Sweden did not work, but even if Sweden worked, we are not Sweden, right? We have a more heterogeneous population regarding poverty and access to health care. So, but it did not work, and it's a disaster there. So, trust is earned, right? And so we have to earn trust. And I think we could use maybe our 3 of my 4 C's, right, to earn that trust: candor, communication, and commitment. And finally, we need to ask the communities affected, what do we need to do to earn your trust? We have to go out and ask them that question. We want your trust. We need you in clinical trials. We want you to feel good about taking this vaccine or the flu vaccine. We want you to trust us as a healthcare system, and we need to ask them, what do we need to do to earn your trust?
Thank you so much, Dr. Harris. I'm going to turn it over in 10 seconds to Shimita to close us out. But first, I just wanted to say a tremendous thank you to you, Dr. Harris, Dr. Albert, Dr. Maine, Dr. Del Rio, Dr. Cochran, for joining us. And this is obviously a conversation that will continue. There are many things that I learned here today, and I know our attendees learned as well. There are many questions we didn't get to that we will put in our FAQs for the ABC, but we will have follow-up webinars because we're learning a lot about COVID, and in the process of this, learning about ourselves as a nation and how we address these disparities. So thank you all, our panelists, and thank you participants. And Shimita, you can close us out. Thank you.
Thank you, Dr. Feely. And by closing us out, do you mean ask my last question? Or?
Oh, you can. This is your show.
Okay. So the last comment that Dr. Harris made, like just this concept of earning the trust of the people, I really like that. And I think that's something to kind of keep in mind because there has been so much abuse of the Black community vis-a-vis the medical ecosystem. The final question, there was a movie produced in 2017 titled Unseen Enemy, effectively predicting this pandemic. There's of course also Bill Gates' TED Talk, And Dr. Del Rio mentioned that, we had pandemic preparations, but obviously we were grossly unprepared. We can assume there will be another crisis maybe within the next 10 years as the world is getting flatter and globalization is happening. What do we need to do? If everybody could just comment, like, what do we need to do differently to prevent this sort of catastrophe? What's our proverbial never again in this crisis? Thank you all.
Let me just ask that we take it in this order: Dr. Maine, Dr. Del Rio, Dr. Albert, and Dr. Harris.
I'll just say very briefly that the never again for me is to never get caught again by surprise as a society. There were plenty of warning signs that this was not a possibility, but even an eventuality, and we got caught surprised and unprepared to manage it in a structured and coordinated way. I think elements of the response have worked, and I'm again proud to say that the pharmaceutical ecosystem has done a great job of responding, but it needs to be well beyond that. And hopefully this will be a learning experience for us as a society.
Great. Dr. Del Rio?
I think that my never again is similar. I think hopefully never again will see a pandemic evolve in front of our eyes and watch it evolve, as opposed to acting a much more effective way. I mean, why did we have to wait to have, Abbott and Roche and all the companies develop testing until March or April, when we could have started in January? I think that we should have had a call to the leadership from day one and saying, okay, what are we doing about this, and how are we confronting this, and how are we preparing ourselves? I think we were caught sleeping, and hopefully that will never happen again.
Thank you. Dr. Albert?
Yeah, I agree with the previous speakers in saying that I believe that Bill Gates did say in his talk that, if we have, sort of these sequences of viruses and bacteria, then it just takes, sort of little tweaks in those sequences, and we have those pre-prepared. Such that from a scientific perspective, that we are scientifically prepared to act quickly. I definitely think coordinated leadership at the federal level, which then informs what's happening at the state and local levels, would hopefully a coordinated approach will happen in the future.
Thank you. Dr. Harris?
My never again is never again should we be caught unprepared. That's a theme here, but that means something. That means that we have to make sure that public health at the national, the state, and the local level is fully funded. And we should all, as citizens, know the status of public health emergency preparedness in our area, in our state, and in our country.
Thank you, panelists. This was outstanding. I do want to add, unfortunately, I'm not trying to be a downer here, but the revelation, and this is not religious, it's just the truth. What was revealed to us by the pandemic is what's always before our eyes. And all of you spoke to that, the disparities. Wouldn't it be great if we followed Dr. Satcher's rule, David Satcher, the previous former Surgeon General, when he said if disparities were eliminated, we would have almost 50,000 fewer deaths nationally. Recognizing that when one is ill and vulnerable, the entire community is vulnerable. You just can't build walls to prevent viruses from spreading. So I hope that our never again is to take a serious look at ourselves and how we view the other amongst us, because how we view that other is indeed a reflection of ourselves. Shimite.
Thank you, Dr. Ofili. Thank you, everybody. Dr. Ofili, Dr. Del Rio, Dr. Harris, Dr. Maine, Dr. Puckren, Dr. Albert. I would like to call myself a doctor too, as I'm a JD, but I won't do that. Thank you, everybody, for joining us. The Association of Black Cardiologists, Columbia Black Alumni Council, the National Minority Quality Forum, and Black Enterprise. Thank you all for tuning in, and have a good day. Please stay safe, and we'll see you again at the next Koruna Talks. Thank you.